once he joins, I'll pause and then let him speak. Is that okay, madam? Can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
Yes.
Okay, okay. Renuka, madam, it's okay, no? I will pause when Prof joins. Okay, I'll start then. Just give me a moment. Dr. Anga is calling. Okay, everything is according to the schedule. So, can you see the presentation?
Yes, sir, we can see.
But it is one-to-one. Why don't you put it into the one slide format? Because we can see two slides together.
Is it okay? I'm in full screen.
Yeah.
Yeah. Okay, give me a moment. How is it now?
Still
Can see in full.
we can see two slides.
Yeah, still we can see the two slides. I think you should really go to the presentation mode.
Yeah. Oops. Now how is it?
Now it is fine. You
Okay,
can go.
fine. Okay, thank you. So this lecture is about just letting go of some of the traditional what you have already been doing and what you have learned. It's about unlearning and reconditioning yourself into certain aspects of wound care. Some things might not be relevant to you. Maybe you all are already practicing scientific wound care. Maybe you have old school and you've been doing some certain things. So just just listen to it and make a discussion and just enjoy the lecture. So just to start off, uh, I would like to ask a few questions. Should antibiotics be used? I mean, must they be used in wound care?
No.
Is it a necessity, the antibiotics?
No.
Okay.
No.
So
Depends on the wound.
Anybody has any other argument?
Depends on the wound.
Right. Okay. Good. So, are expensive dressings better?
No. Not at all.
No.
Anybody has anything else to say?
No.
Okay. So, but I mean, just to ask,
Maybe.
why are they there then? I mean, they are so expensive. People have spent a lot of time doing research on them and all that. So just to think about it, just think. Yeah. So, there are one advanced dressing to treat all wounds.
No.
No.
Good. So if there's no progression of a wound, what should you do?
Yes.
Just change to another dressing, better dressing?
Yeah. Yeah.
Change.
No.
Okay. Right. Anyone else?
Yes.
Yes. Okay. Yeah, I heard a no also. Okay, good. So, uh, should the patient come to you for always for dressings? Are home dressings really bad? Should you not encourage them?
Mhm. That is depend on the patient. Cleaning, hygiene. Depend on the
Okay.
patient's hygiene.
Right. So, I mean, it's bad for the pocket, of course, but are they really bad clinically? No.
Yes.
No.
No.
If you heal, say, I mean, it's like, say, it's a bad omen, this wound is. So, if you heal another one, heal one, there'll be another one. So, this notion is there sometimes. Just
Say yes.
so people have this thing. So the other thing is, is it a karma to have a wound not healing?
No.
Just some things that we encounter day in day out in wound care. So does these Hela Deshiya methods? What do you think about those things? Do they work? I mean, do you believe in them?
No.
Okay. Anyone else?
No.
No.
Okay.
They were there because
Okay, now, so no, I'll just leave this as it is now. I'm not going to answer anything right now. So now here's a wound. So the whole exercise is to try to get this wound healed without any complications and possibly with much less scarring and all that. I mean, we need it healed like it was not there. Is that right? So, what happens when you get a wound? When somebody gets, let's say, your any animal gets a wound. I'm talking about skin wounds here.
Naturally healing, right?
Yeah. Any others want to answer? When you get a wound, what happens?
Keep the wound clean.
Yeah. No, I couldn't hear properly.
Can get infected.
Right. Now, let's say an infection. Okay, that's a complication. So no complications. Usually, about 99%, what happens?
Majority here.
healed by
Naturally.
itself.
It's
It naturally heals. Yeah.
Yeah.
When you get a wound, it heals.
Yes.
Yeah. So how does it heal? How do they heal? Is it a very simple mechanism? Is it a complex mechanism? Let's see.
Complex mechanism.
This one.
Yeah.
Acute inflammation going to wound healing primary.
Yeah. When you have a wound, the first thing is, I mean, you will learn this in depth, for a certain depth, in the next lecture, the wound biology. Dr. Anga will be doing it. I am just trying to uh, to potentiate some thought process. So this is what it is. This is what I mean. This process have been there from the beginning of the organized uh, creatures. Let's say it's very old. So now now only we have divided these into phases and all that, but it's a continuous process. So we have divided this into four processes. What happens once the wound occurs, there will be hemostasis for about 15 minutes. Then there will be the inflammatory phase, then proliferation and maturation. I'm not go into these depths. So how does this happen? I mean, there's a continuous process and there are four stages and all those things. The nature is really organized. There are certain things that at work here, like the keratinocytes, they do quite a bit of things. I mean, ECM, there's a clot formation, there's a clotting cascade, which is quite complex, and neutrophils coming in. There are granulations being degranulated, and there are fibroblast formation, granulation tissue formation, neovascularization. So many things happening. So many things at work. So there are. I mean, don't worry about this what these things say. So there are so many signaling mechanisms. There are so many hormones, so many cellular uh, uh, chemicals involved outside the cell and inside the cell. So what I'm trying to say is it's very complex. It's very complex. And how did we get this? It's through evolution. So for millions of years we have been these have been evolving. It's a very strong, complex mechanism. It's very strong. This healing process is very strong. That's why you don't see your dog, cat, or any pet. They don't go and wait in a queue to get their wounds treated. Very strong. 99% of wounds, I guess 99, maybe 98% of wounds, they heal. So you see this picture, the first to your left, and it's almost nothing at the end of the four phases. So it's very strong, and this is one of my patients. See what has happened. I mean, this is day 2 after debridement. And then here, after about 6 weeks, this is the outcome. It's like it was never there. So with time, after about a year, you don't see even this, just a bit of a scar. So all this mechanism puts you in a balance. It's not actually a balance. You are biased to healing. The body is biased to healing. So any patient, anybody is biased to healing. So there are things that will make it unbalanced or biased to non-healing. Is that clear what I'm trying to say? So this process is there, very strong process that will push us towards healing, and there are certain barriers that will block it and push back the healing process. So these are the things. These things you have all already learned. Clinical, poor tissue perfusion, if there's necrotic tissue, high bacterial load, edema, a lot of exudate, say other skin problems, hypersensitivity, eczemas, the dermatitis, whatever, then the malnutrition, protein malnutrition, systemic conditions, dehydration, all those things and psychosocial aspects also you must have learned somewhere. uh, pain pain is a barrier to healing. Pain reduces healing, and your sleep also affects healing, and altered mood, social isolation, everything affects to healing in somehow other. Like you get the patient won't be motivated to get the treatment. So lack of education, lack of support, inability to self-care, all those things are coming in the psychosocial aspect of barriers. So you must have come across all of these. So what about these things? Your knowledge, what you have, what your teachers have given you, and you see someone doing it in a surgical ward or in a wound care practice. It's ritualistic practice. It have worked for them for a long time, and it have work because of what is the other problem. Now you are working with this very strong mechanism. You can't beat it. You can only support it. This the mechanism of healing. So maybe the wounds heal with this ritualistic practice and traditional practice because the wounds were anyway going to heal. You were just there collecting money. I don't know. You must have seen these things. There's quite a bit of a chance that the wounds that are being treated in some of the clinics might heal with just home dressings, with guided home dressings and a bit of water. In the sense, some moisture. Not needing a lot of other expensive dressings or frequent EOD visits to the wound care place, spending about 5,000 rupees on the way to the three-wheel driver. So you get what I'm trying to say. So there are educational barriers, say appropriate to inadequate training and support, lack of understanding of research process, poor quality research, and you have the good quality research, but you lack the critical appraisal skills to know what they're saying. Negative attitudes towards evidence-based practice, we don't need it. Most of the traditional say practitioners, say not the allopathic practitioners, the other people, they don't practice evidence-based medicine, but they don't want it also, and there is always information overload. So all that can happen, just have that in mind. All those are barriers to healing, in the sense whatever wound you are treating, all these things can come into play. And there are professional and organizational problems as well. So there are no consensus on how to treat certain wounds. Like this, there are some wounds in wound care world, we say God knows what these are. So there are no those are mostly some dermatitis and the some aspect of pyoderma. They usually go as venous ulcers, which they are not when you dig deep and do some research. So those things we have to research more, and we have to have expert opinions, more consensus among the experts. So, and inconsistent research findings, no standardization of practice, interprofessional rivalry, those things also come in. So, lack of effective clinical role models. So those are there. So that's why what we are going to address. That's what we want to address. So and there's always lack of resources, instability of health services. We have seen this happening a few years back. And lack of focus on wound management is something that we are already having, and we had it for a long time, and now we are going to change it. The causes like these are about this last thing, lack of focus on wound management. So, see, there are so many barriers. So you have this strong mechanism, and there are some barriers, and you have a chronic wound. When you see that, your reaction should not be putting a dressing and send him away. You have to analyze that wound and unearth and understand what's happening and what is the barrier. That is the cause for non-healing. You treat the causality. So that is very important. So you have to find the cause for non-healing and treat the cause. Dressings are about 10% of wound care. Most important thing is the wound diagnosis and finding the cause and treating the cause. Otherwise, there's no wound care. So then you are going to treat a wound. That wound didn't come to you, did it? The patient did. So, like any other aspect of medicine, you have to treat the patient first. The patient has the patient with this large non-healing wound has various other medical problems, psychological problems, social problems, economical problems, spiritual problems. It's just like palliative care. So that's why the holistic wound management is important. So you first approach the patient, not the wound. Just put a dressing and send him away. No. Then he will be coming for about 3-4 years, and wound will eventually heal by chance, not because of you. Not then have you done the reasonable job? No. So anybody has any questions up to now? Anything to argue? I mean, I would like somebody can share some insight into anything that they have undergone or any patients, any personal experiences. No, okay, moving on. Now, yeah, time is always a concern. So medical comorbidities, you know these things. Maybe having diabetes, uh, any other medical illness, say heart failure, all those things can affect renal failure, all those things. Maybe the patient is having a transplant, he's on all the prednisolone, tacrolimus, and all those things. So they all uh, gear down the healing process. Nutritionally deficient. So many medical problems to think of. So psychological aspects the patients are usually depressed and they are anxious. Maybe there is a patient with a psychotic disease, with a wound, and the patient may be in delirium, or the patient, most of these chronic wounds we see at the latter stages of life, they can have dementia as well. So all these things matter. These guys are not really capable of self-care, and they do repetitive movements, repetitive, you can't stop them scratching on the wound and all that. They might hit the same place. So those are things that might happen. So their medicine might affect the wound healing. So and can't feed them properly to get the nutritional balance. So then the social aspect. Just think about, say, we want to do some home dressings. We are going to advise some home dressings, whether it's possible. So, and the patient's overall care, we are advising him to take the medicine, bring him to dressings or get the dressings done, or about the nutrition, we ask him to give about 3, 4 eggs, 5 eggs, and keep him hydrated and all that. So, is it possible? Who's taking the responsibility? Who's the main caregiver? Whether help is available when necessary, whether they can travel, and how practical are clinic visits? Say, you maybe, I don't know how many of you all practice EOD dressings. Some answers, please.
No, I'm from
I
DH
practice,
Center,
madam.
Division Hospital Center.
I
We are
practice, sir.
usually doing
At
EOD.
Division
EOD
Hospital,
dressing.
sir, we have
Yeah.
EOD.
So how practical are EOD visits for patients? Say, I mean, to come to this place, they have to spend on 3 wheelers, and get to they have to have a helper. So many issues.
Even the
And
weather sometimes.
Mostly they're coming. Only the bed-bounded patients are not coming, but mostly patients are coming because they
yeah,
have a.
so
Yes,
imagine the economical burden. So wound care consumes extensive healthcare resources. There have been so many research on this. So you have to always think about whether the travel and other expenses are they bearable. EOD dressings. Just think about it. Whether the dressings are affordable, whether the whole treatment plan is affordable. And when a patient comes every other day, the patient doesn't work. Caretakers also doesn't work, and that's a huge loss to the economy when you do it repeatedly. Just imagine, the patient might lose the job, and how is the patient going to recover as a productive citizen? I mean, now the whole scenario of medicine, we are not the money makers unless you go for foreign training or foreign jobs and make some dollar revenue to Sri Lanka, which is also happening. But mainly our function is like we fix the machine. We just fix parts of the machine and fix it back to where it is. And the whole economic machine, the machine should run. Otherwise, there's no profit. There are no way to fund the your all the facilities, roads, electricity, water, all those supplies cannot be sustained. So each and every patient should ultimately be productive, not the people who are retired and at the latter stages. But they should not be a burden also. So just think about those things. So any questions, anything to share up to now? Anybody? Have you thought about these things earlier? When you are doing EOD dressings, have you all thought about these things?
I mean, when we used to work in DGH in Orally, so there most of the patients, they save money to come, and there's no bus. So then yes, I remember that sometimes we admit the patient because they can't travel up and down. The cost is so much that he can't bear it for the rest of the family.
Yeah.
But then some of the wounds surgeons really require it to be just EOD, and even we can't advise them to do dressing at home because the cleanliness and the knowledge levels are not sufficient to get it done at home. So then we really need them to come to get the care properly given to them.
Yeah. So those are the issues. It's true. So yeah, I mean, admitting for wound care, yeah, we also do that. But the problem is now, say you are transferring one problem to another problem actually. So I think the government is spending a lot on admitted patients. The idea is to get the patients out of the hospital as much as possible and as soon as possible. So reducing the burden on the health budget. So just to think about these things, just always think about these things. So that's why we should find the cause and treat the cause and get the wound closure as soon as possible. So that's the idea. So uh, so a patient comes to you with a wound comes to you, 69-year-old male with poorly controlled diabetes, right foot ulcer for 3 months, treated at various places. So what now? How do you approach? So it's like any other aspect of medicine, say internal medicine, cardiology, respiratory medicine, or whatnot. So general surgery, whatever. It's just like that. History examination, if necessary, only investigations, and then problem identification and management plan. So the approach, the history, you should ask the start, duration, progression, pain, fever, claudication, all those things. And previous investigation, has anybody seen any clinical records and all those things? And not to forget to get the risk factors for wounding, non-healing, and rewounding in such patients. It is important in prevention. So anything about the comorbidities and all those things should come into this history. So examination, whether the patient is septic. So BPPR, temperature, all those things come into that. And you can get the SIR score, the systemic inflammatory response score also. Jot down, then that will give some sort of a value to for you to do the intervene or not, just to decide. So whether there's obvious signs of anemia that which can be can be a barrier. So infections, ischemia, peripheral ischemia, and signs of other chronic diseases like heart failure, you know, uh, poorly controlled diabetes, kidney failures, and something that might affect the wound healing if the patient is on steroids for SLE and all those things. So rheumatoid arthritis. So the wound itself might be a manifestation of such diseases. So all those things to be thought of. And just to think about the mobility of the patient as well. And the psychological aspect I haven't included in this, just the mood and all those things is better to notice. And of course, the psychosocial strata, education, all those things has to be assessed. So investigations, of course, the basic blood. Anybody wants to say anything? So investigations, basic bloods, full blood count, a random blood sugar or a capillary blood sugar. Will do CRP if you are thinking of sepsis. So systemic sepsis. Culture and ABST if necessary only. It's not mandatory. In chronic wounds are anyway colonized. Mostly they are colonized. You will get a culture, but it doesn't convert into any intervenable or whatever any uh, uh, data with a value. So mostly not. So the problem is mostly the biofilm rather than what is in it. So, and most of the biofilms also you can just, there are a lot of telltale signs rather than getting a culture done. X-rays and MRIs to figure out whether there are correctable causes like deep-seated abscesses, X-rays for osteomyelitis and all that. So those as indicated and if necessary only. So now we have assessed the patient. So now only the wound. So first thing is to describe to yourself and to a colleague and to a senior in technical terms. So just try to describe it to yourself, the anatomical place and the size in centimeters or inches and the shape. Whether it's an oval thing or so. And what's in the base. Whether they are slough, whether they are pus, whether they are necrotic tissue, whether there are any important structures like tendons, whether there is granulation tissue, and whether the granulation tissue is good or bad. So how do you know it's good granulation tissue or bad granulation tissue? Just a moment.
Redness is the good granulation tissue.
Give me a moment. sorry, yeah, something which is relevant to this. Okay, so carrying on. So just yeah, I was asking about good granulation and bad granulation. So how do you identify good granulation? Yeah, go on.
Good redness around
Yeah,
the edge of the redness. That's why that's good granulation.
yeah. No, can't hear properly what you're saying. Yeah,
Yeah, edging of the wound, redness.
right. Okay.
That's why I am thinking this good granulation.
Yeah, it's a pink, very uniform, beautiful thing. I like pinheads. So, do you think there's good granulation in this wound?
This one seems to have a mix of sites. No, certain areas have to have some uh, areas of good granulation, especially like the at the proximal at the start of the wound, closer to the ankle, because this seems to be the dorsal area of the foot, left foot, probably.
Yeah. Hmm.
So at the area near to the ankle, there seems to be some bit area of some good granulation, but it's mixed
Yeah.
with some slough, and there is necrosis, and the tendons are exposed.
Yeah. Yeah.
Yeah, and
Yeah.
there
Just a
towards the
bit of good granulation and yeah, bit of epithelialization and all that.
so towards the toe end, there's gangrene and some necrosis, and seems to be a previous amputation as well. So
Yes. So, yeah. So, base the color of the wound, the depth, what is the edge doing? All those things are important. Whether the edge is uniform, it's rolled up, rolled over, you know, puffed up. So each means something, a different type of wound. So whether the drainage is too much, scanty, so all those things have to be noticed and described. So what the surrounding skin is doing, whether it's macerated, is it sort of eczematous, is it normal, there's cellulitis in the vicinity, and there are any alarming signs, like whether it's bleeding, is it grossly infected, pus, any bones jutting out, or anything that is there anything that needs immediate attention and intervention. So those things are important. Just a moment. So, any questions on this? Because you will have to use this in your assignment. I will send another set of presentation, the slides also on how to describe a wound. So this will be one of your one part of your assignment. You'll have to describe your wound. You have to choose one and then describe, and then go on to doing the wound biology and all those related to that particular wound. So you have described. So now what?
excuse me, sir.
Yeah.
Just to
yeah.
clarify in that picture, in the wound, towards the toe, the tissue, the change there, so that is what we classify as maceration.
Yeah, you can say that. Now, Professor Mandika Vijayaratna, I welcome Professor Mandika Vijayaratna. He has joined. Professor Mandika is the person who has put us on the path to learn wound care and do a lot of wound care stuff, and he's the grandmaster, if I may say. So I think the official welcome must be done by the our president, Dr. Renuka. Madam, are you there?
I'm there.
Yeah. Will
I
you
think
introduce? Yeah.
I think Professor Mandika Vijayaratna does not need not much introduction. Everybody know him because he was the professor of surgery in the Colombo Medical Faculty, and he has been doing great job with. I mean, he was doing the vascular surgery and then doing the transplant, and then he was very multitasking person. And when it come to wound care, he was trying to teach most of the his juniors, and then he was trying to establish these wound care practices in the proper manner during the past years. So we are very happy to have you, Professor Nandika, and it is an honor to have you. So I would like you to address our colleagues that who have joined this wound care management course. So please, it is over to you, Professor Nandika.
Hello. Good evening. Thank you, Renuka, for those kind words. Tusita, I'm really impressed with the number of those who are interested in wound care. That's really very heartening to realize that lots do actually appreciate that wound care is more than just replacing a dirty dressing with a fresh one. As Renuka said, I've been involved in wound care for the last 35, at least 35 years. And that was an era where very few doctors were interested in wounds. Sad to say, even today, though there is greater interest, still it is the nurses, and during my student days, it was the hospital attendants who used to change dressings. And that was wound care, change of dressings. And the nurses, doctors, all they did was prescribe antibiotics, even without looking at a wound, because wound care equals antibiotics from the doctor and change of dressings by the nurse. So we have come a long way since, and we understand the biology of wound healing, which is the scientific basis for whatever we do. And this learning, the training program, I'm sure is going to address all these important areas and teach you how to assess the wound. I think the assessment is the most important. Changing the dressing anybody can do, but assessment is the foundation. And you, based on the assessment, that you plan what to do and not to do. The dressing is only an essential, but only a small part of wound care. Wound care is not just focusing on a wound. It is that part of the body, and finally the patient. And actually, it goes even beyond the patient. There's a family, a community. All of these people are very seriously impacted when there's a chronic wound. It goes way beyond the patient. So I hope at the end of this course, you would have come to appreciate how huge even the one person problem is, how huge it is. And you will be able to give a better service to these patients based on what you will learn during this program. There's another thing which we wound carers have learned, there is a connection between you and the wound. It's not just a robotic thing where you just do an assessment. Now, today you will see AI, artificial intelligence, is being used to assess all aspects of wounds and even prescribe a dressing. But finally, there is a wound carer and a connection between the two parties. And these are things that we have just observed, felt. And now there is also scientific evidence that this connection, this concern, care, adds to the power of the individual wounds to heal. You would have noticed people saying, "Me doctor ළඟට යන්න ඕනේ, me nurse ළඟට යන්න ඕනේ." මොකද, they think there is some magic between magic in that person, and that magic is the care, how the person interacts with the patient, and the wound problems are only increasing because people are living longer. One of the main reasons for difficult wounds is diabetes, and diabetes is increasing, and you're getting more people living longer with diabetes, and the wound problems are exploding. So there's a lot of work for those who are interested, and I hope this program will teach you to care for these wounds with a scientific basis, a scientific approach, and you will have great success. And finally, I must tell you, the satisfaction you get by healing a difficult wound goes beyond words. Patients, families, and the wound carers get something more than what anything else. What money can give you is nothing compared to the satisfaction and the goodwill that is developed between carers and the effect. And I hope you enjoy and you learn. To learn, you need to ask questions, so don't hesitate to ask your questions. There are no foolish questions. All questions are, your questions are valid, and that you will learn and make the best out of this educational program. Thank you.
Thank you very much, sir. It's always a pleasure to listen to, and we always learn something. And thank you very much at this the latter part of the day after your exhaustive work, joining here and sharing your immense energy, a little bit of your immense energy on wound care with us. And it's a pleasure, sir. So
Thank
let's.
you, Mandika. Thank you, Professor Mahadika, for all the kind of support and the joining at this time of the year, time of the day. Thank you so much.
And
We always appreciate your support.
Madam, I think we can the group can listen to him on 26th. No? There will be a question and answer, the frequently asked questions.
Yes,
And
this time our palliative college webinar is done by Professor Mandikal. So the topic is wound care, FNQ from the Grandmaster. So you can keep all of your questions and ask all these questions from Professor Mandikal on 27th, and that is next Thursday from 8:30 to 9:30 p.m. So all of you are welcome. Please come and resolve all of your issues and ask all the questions from Professor Mandikal.
Yeah, please write down the questions before you forget.
That's true.
Okay.
Okay, sir. Thank you very much for joining, sir. Then I'll continue with the
Please,
session.
yes.
Okay, thank you. So So we were talking about the wound, how to describe a wound. So was there any questions on this? So now you have described yourself the wound. Now what? Now is the time to diagnose the wound, see what it is. So can be ischemic wound, can be a venous wound, pressure sore, osteomyelitis, vasculitis. So this is the we will be doing the wound diagnosis later in the lecture. I'm just guiding you to just trying to draw a line of thinking. So once you have described it, the next step is to diagnose it in which part of the spectrum of chronic wounds your current question lies. So maybe due to less the less perfusion, maybe due to venous pressure, maybe the patient is sitting on it or walking on the wound, or there can be a dead bone, or can be due to something else in the blood. And the next thing to decide is whether it's a healable wound or just a maintenance. Most of the time we see these, for example, uh, these bed sores in the latter stages of life. We don't really try to heal them. They might heal, but the mainstay of the treatment is to relieve the patient of agony and to maintain uh, and treat the symptoms. So whether it's a healable wound or a maintenance wound. So if it's a healable wound, let's start treating. So do that. There are uh, certain principles that we follow. The wound bed preparation, there's a principle called time principle, which uh, breaks down into tissue management, infection and inflammation management, moisture balance, epithelial edge advancement. So these things came up not really recently, but they are from 2000, it's like early 2000s. So this is being changed also. There are more additions as well. So this will be discussed in the second week in uh, in depth. So tissue management means there's dead tissue, necrotic tissue, slough, all that. What to do, how to do, like how to remove it, whether to use sharp debridement or chemical or that sort of thing. And infection control, whether to drain and how to clean it up and to what sort of antiseptics to use, washouts, and all those things. And moisture is 99% of wound care is moisture balance. So once you have corrected the cause, once the blood supply is accurate, once all the patient's concerns, the comorbidities and all those things that we have to discussed about are corrected, and if it's a healable wound, you do the moisture balance. If it's more, you take moisture out. If it's less, you give moisture. So there are ways and means of doing it. So we'll be discussing that as well in the second and the third week. So epithelial edge, how to support the epithelial edge advancement, what sort of dressings or what sort of moisture and are there any other things that we can help? Maybe you can secondary suture and finish it off as well. So, what nutrients effects the say zinc might affect the progression of the epithelium? So those things, those will be discussed in detail. Any questions up to now? I mean, these things will be discussed in detail in the next coming weeks. So then to the dressing selection, once you have done the wound bed, is the dressing selection. So there are certain types of dressings: moisture adding, moisture removing. There are antiseptic dressings. There are certain dressings that have antiseptic antiseptics incorporated. There are adherent, non-adherent dressings, and there are certain additives. So it all boils down to what is ideal for this particular wound. So you have a elderly with a foot wound. So what is ideal to that foot wound in that particular elderly with certain problems? And there are maybe the wound is dry, then you have to add. Maybe the wound is septic, then you have to use an antiseptic. So there's a method to decide. So it's not a you can't say this type of wounds goes with these dressings, they heal with these dressings. It's always an individualistic sort of approach. So how do you decide what is ideal for this wound? There are a few major questions. What's the moisture level? Do you have to add? Do you have to remove? Whether there's infection? Whether it needs debridement? So if you can't do a sharp debridement, you might have to do it with the dressing. There are ways and means. So do you need any other function? What do you mean by this? Any other function is whether you want to offload, whether you want to apply a bit of pressure. So that sort of thing. So dressings, just to talk a little bit about dressing. There's a separate lecture on dressing selection. So all this will be discussed again. Just think about there's a primary dressing that goes onto the wound, and there will be a secondary dressing covering it and supporting it. There will be a tertiary dressing which will apply compression, might offload, and all those things. So just to talk a little bit about offloading. And why do we have to offload a foot wound? Now we are talking about the foot wound. So this case is about a foot wound. So foot is the one that bears our weight. So that's why we have to offload that particular area with the wound. Otherwise, it will never heal. Repeated shear, repeated pressure, ultimately end up with osteomyelitis and amputation. So how to offload? Again, we'll be discussing this. Basically, you can do it with the dressing bedside, and there will be orthotic ways and means of offloading it. Footwear, customized footwear, or you can get the patient to do their sort of crude offloading footwear as well. So the next thing is planning the review. You have done all that and planning the review. So you are talking about EOD dressings. So is that the way to go? What do you all think? So most of you all said you all are practicing EOD dressings. What do you think about EOD dressings after listening to all this? Come on, I know it's the sort of end of the day, but we have to finish also. Yani, I would like some answers.
I think it's kind of like, where one particular way of treatment doesn't fit all types of wounds. And some EOD might actually worsen the wound because when you keep removing it, you're removing healing granulation tissue along with it as well. So you might be prolonging the healing process rather than improving the healing process.
Okay.
I guess it varies.
So anyone else want to share? Okay.
It
So
can increase the cost to the patient and increase the burden if it is done in moments where it is not really necessary.
yeah. So that's what we were talking about. So good. So so planning the review also, it depends on the individual, depends on the wound, that particular wound. So what it needs, what the patient needs, what the patient can afford, what's the burden on the economy. So all those things come into play. So most of the wounds, almost all of the wounds, I think does not need EOD dressings. We have to let it heal a little bit, maybe every fourth day, maybe weekly, and some might even need daily looking at it. But most of them don't. So EOD dressings, the concept of EOD dressings, you all have to decide whether you keep it in or just leave it aside. So that's the whole idea of this lecture. That's why it's called disruption, just to unlearn some things. So then what's next is just to talk a little bit about antibiotics. So now most of you all correctly said antibiotics are not needed. So if you are going to, I mean, antibiotics are very complex chemicals. The process of making them are also very complex and very expensive, and it's very difficult to come by a new antibiotic in this era of non-communicable diseases. So better not uh, waste antibiotics on wounds. That's what I think. Uh, if you are using antibiotics, should be very rational, and the correct dosage, correct timing, and all that. And it should be a targeted approach. So, any ideas, anything you want to add on this? So, okay, moving on. I think Dr. Angi is also waiting. Next is wound prevention. There's a whole lecture on this. Just to uh, uh, for completion. So we'll be talking about this, but so prevention, skin care, all those things, food care, footwear. We'll be touching all these things. I mean, each is a separate lecture, but this is a short course, so we'll be touching on this and we'll be giving the basic ideas. So just to show what's happening in the bedsore prevention, just have you all have you all seen these lateral wounds, hip, greater trochanter, thigh wounds, say leg wounds in the leg, and the ear? Anybody has seen all this in these certain lies? Even if the patient is seated, we ask them to ask the caretakers to keep them seated. Even with the seating position, you can have sacral, hip, shoulder, lower hip, feet, all those can be affected. So just I'm just showing you that there are things to think about. So when to refer is also another important thing. I'll just finish this off fast. See, If there's no distal pulse, refer. Nothing magic is going to happen if you keep the patient. Just refer. And there's dry gangrene. Again, it can be of vascular origin. There's something happening. Body can't push that uh, anything that can potentiate healing towards that area. Big problem. Refer. And if you suspect sepsis, I don't think we can do much in the primary care. So better to get an opinion. So just pus, unless if you are really fluent in cleaning it up and preserving the functionality, you should refer. There's excessive bleeding, yes, you should call for help. If the wound is spreading, definitely refer, get an opinion. If the associated medical conditions, the comorbidities are escalating, definitely refer. Don't wait. There are no progression. That is the most important thing. Just don't try. Say you are putting 500 rupee dressing. Don't go to the 1,000 rupee dressing and 50,000 rupee dressing. No point. Just get an opinion or go back to the drawing board and think what's happening. You do nothing comes straight. The same thinking patterns comes. Refer. So just to talk a little bit about research, it's very important. You have to practice evidence-based medicine. So you can, if you are not a big researcher, you can tag along with the major investigators. There are certain names, so you will get told of these guys, and then just read what comes out of them. So just learn to read technical jargon fast. And definitely do not learn from the drug rep. He has a marketing degree or a diploma. He is not from medicine origin. So he didn't do medicine. You all did medicine. So evidence is the key. We have to always practice evidence-based medicine. So again, I'm not going to go through all this again because we are pushed for time. So thank you very much. Any questions up to now? So Dr. Ranga is in. Sorry for taking your time. So I think I should finish now. If there are no questions, I'll finish and I'll let Dr. Ranga Perla, consultant surgeon, to continue. Thank you very much
Thank you,
for
sir.
listening. Hope I
Excuse
did.
me, Dr. Tusita.
Yeah.
Dr. Tusita, you said there can be pressure source in seated position, but
Yeah.
in a seated position, we are not keeping patients in seated position for a long hours. I mean, for hours we are not keeping. So how can it be source in the seated position?
No, if you keep him enough time, that's the problem. So when you it depends on now. If you are keeping him on more than 2 hours, yes. Now I have seen patients being kept seated for a long time. That's all. I mean, the basics are basics. You are correct.
Thank you, sir.
So there are no other questions. I would like to finish and thank you very much. So over to you, Madam. Do you have anything to add, Madam Renuka?
No, Tusita, I think you have done the thing. I think Dr. must be waiting now.
Thank you much, sir.
10:50.
So over to you, sir. Dr. Angapera is up next.
Thank you, sister. Thank you. And I heard that.
Shall we introduce Dr. Ang? And then
Yeah, madam. Yes.
Yes. Why don't you introduce Dr. Angapera?
Dr. Angapera is our past president, and he's a eminent consultant oncological surgeon, and he was former dean of Faculty of Allied Health of KDU, and he's our host for the upcoming hands-on session, and he has achieved a lot in his academic career, and I'm not going to take a lot of time on this. I mean, he actually is one of the people who doesn't need an introduction as well. So, one of the leading figures in the field of surgery, and we are very delighted to have him as our class president as well as a lecturer here, and the lecture is going to deliver is on wound biology, and it's actually with the history and all that he orchestrated. He always does a fantastic job. So over to you, sir, for the lecture. Thank you for joining.
Yeah, thank you. Thank you for that introduction, and so little accelerated introduction. Thank you very much. And yeah, so I'll come to my lecture itself. Can you all see this?
Yeah.
Okay,
Yes, sir.
so I'll put it on the slideshow mode. Right. Okay, so I'm very happy to see so many participants this time. I think our number of participants are getting increased and day by day or year by year. So this year we have got 171 or 170 participants for the wound care workshop. I'm very happy to see that. So I'll be discussing about wound biology. Before we come to that, I'll just give some little introduction why we. Right, it's about the wound burden in Sri Lanka. So if you take the wound burden of Sri Lanka, we've spent about 0.1 billion US dollars the wound care of Sri Lanka in 2009. These are rough figures. And 2023, the cabinet approved 3 million meters of surgical gauze for the government hospitals. 3 million meters of surgical, 30 million meters of surgical gauze. Now, they have been spending almost 75 rupees from Sri Lankan vendors and 102 from the foreigners. So if you take Sri Lankan vendors, if they're taken complete from Sri Lankan vendors, we are spending about 2.4 or 2.24 billion Sri Lankan rupees only on gauze. Only on gauze. Not about the antibiotics, betadine, and other wound dressings that we use. Only on gauze we spend this much. And wound care market of Sri Lanka is projected about 1.3. Sorry, I can't see this with this. 1.36 million US dollars, and it's estimated to grow between around 0.49 between 2025 and 2029. So every year, about another 5 or how 0.5 million US dollars being added to this. So by the year of 2020 or 2030, this will be about 3 million US dollars industry for the wound carers. Right. So with that, we come to the learning objectives. We go a little introduction, and then we go to the definition of what are the types of wound that we see in our practice, and a little bit of history of wound care, and process of healing, and phases of healing, and factors affecting wound healing, and a little bit of management of wound care. But our whole course is on management of wound care, so we don't need to. I'm not going to go into detail in the management of wound care. So, in definitions, a wound can be defined as an injury to a body or a tissue that involves damage of integrity of tissue or a body structure. So again, a wound can be defined as an injury to the body that involves damage to the integrity of tissue or a body structure. Healing is the body's response to injury and attempt to restore the normal structure and function. It implies the disappearance of process of inflammation and replacement of either the damaged tissue with regeneration or repair. So that process is a natural process. For us, what we can do here is actually to let that process happen, and every wound will heal if there are no problems of healing. So we'll come to that factors later, but every wound is supposed to heal either with regeneration or repair, and nothing will be there. There would not be any chronic wounds, right? If there's a wound there in a small child or animal or anyone, the process of it to heal. That is the natural process. So if a wound is not healing, there's some kind of problem to the natural process. So our duty is to make sure that the process which is hindering the wound healing is to enhance, or we have to do the obstacle of wound healing to remove the obstacles that making the wound not healing. That is our job. We are not going to heal the wound. Actually, wound healing is a normal process. So ulcer is defined as a discontinuation of an epithelium, right? So it's a little bit of history. About 1500 BC, detailed use of lint and animal grease and honey was used in wound care, especially in the ancient Egyptians, right? They thought that wound should be closed or dressed with a covering. Otherwise, it is a place that the soul can go out from the body through the wound. It's true because if the wound kept open and if you get infected, the sepsis will set in and patient might die. So soul will go through that wound. So Greeks were thought that they have contributed a lot of things for chronic wound healing, and they made that wound suturing and wound care and pus. They have made various contributions, and they are the one who are the Galen is the one who described about the classical features of inflammation, and those things were incorporated into wound healing. 1980s is the modern wound care treatment was started. By that time, we understood, by the 1980s, already we understood the factors that affecting wound healing. The cytokines, the role of macrophages, the white cells, fibroblast activities, and all these things were started to learn during these 1980s. Still, these things are being learned, but the major part was done by 1980s. So new things are coming up because new things are being learned. Right. So types of acute wounds. Right. There are acute wounds and chronic wounds. Basically, types of acute wounds are contusions. Contusions are like a bruise. So that the surrounding tissues are also damaged, and there's a bluish discoloration, and there is no breach of the epithelium. Abrasion is a breach of the outer layer of the epithelium. There won't be any damage to the dermis or the underlying structures, only a hematoma is a collection of blood under the subcutaneous tissue. There is no damage to subcutaneous tissue like any contusion. Contusion will also have a hematoma, but there is no damage in a hematoma. Incised wound are, incised wounds are typical cut wound. Lacerated wounds are typically a tract wound. Commonly happen in the scalp, right? So if you hardly hit the scalp, because the tissue layers are bit of tougher tissue than the other areas, and the underlying skull is also tough. So what happens? The skin get cracked, right? Crush wounds, mostly the machineries. If someone get caught into machinery, the tissues will get crushed, right? Other common thing is the penetrating wounds. So these are not the acute wounds are not the thing that we are going to discuss most today. We will be discussing on the chronic wounds. The chronic wounds are either the ischemic wound or a diabetic wound or a venous ulcer, vasculitis. and pressure. Also, those things are the chronic wounds. Those happens mostly spontaneously, or they may start as a traumatic wound like incision or cut injury or a laceration and will not heal because of other factors, which are factors helps the wound healing is not there in these patients. Right. So these are the arterial ulcers, venous ulcers, varicose veins, and various things will cause wounds healing being hindered. We will discuss those things later. Right. Neuropathic ulcers, diabetic pressure ulcers. Those are the types of chronic wounds we'll discuss. Vasculitis. Right. So basic physiology of wound healing. The process of healing involves two parts. One is regeneration, and another thing is repair. The regeneration is when healing takes place by perforation of parenchymal tissue. So basically, we have two types of tissue: the parenchymal tissue and the mesenchymal tissue. Parenchymal tissue is, or parenchymal cells are the cells which that makes that organ specific cells. Say, for example, liver will have a hepatocytes, are the parenchymal tissue. Kidney will have kidney tubules and the glomeruli are the parenchymal tissue. And the other tissue are called the mesenchymal tissue. Those are the connective tissue which support the parenchymal tissue to stay on that organ in a specific manner. Those are called the mesenchymal tissue. So when the wound takes place by perforation of parenchymal tissue and replacing the damaged part of the organ with same type of parenchymal tissue for the same completeness, we call it regeneration. And if the parenchymal tissue cannot be replaced, then what will happen is the mesenchymal tissue will restore the gap and cause scar tissue. That is called repair. So regeneration and repair. Sometimes both will happen. Regeneration and repair both will happen at the same time, and the normal tissue function can restore. Sometimes the repair is more predominant than the regeneration, so mostly there will be scarring. Right? So when these things happen in an abnormal manner, this is what happened in liver cirrhosis, where there is repair and regeneration both occur, and the liver will have problems because of repair and regeneration. The fibrosis will occur in the liver as well as there is regeneration. So there will be nodules will be there, and there are fibrosis throughout that area, and the fibrosis will contract, and that will increase the portal pressure. That's what happening there in tissue damage, but that is nothing to do with wound healing. But this regeneration and repair both happen in the liver cirrhosis. Right. So we go into regeneration in little depth. So some parenchymal cells are short-lived and while have other long-lived. So maintain the proper cell tissue cycle. These undergo regulatory control. This control is made by epidermal growth factor, fibroblast growth factor, platelet-derived growth factor, transforming growth factor. So all these growth factors, I'm just listing you these five. These are the most important five, but there are more than 100 these types of growth factors are there. So proliferation of original cell from margin of the injury to migration into the covered into the injured part that cover the gap is called regeneration. So proliferation of marginal cells subsequently differentiate and mature into a reconstructive original tissue. That is what we call regeneration. Repair is the replacement of injured tissue by fibrotic tissue. Two processes will involve in repair. Granulation tissue will found the formation, and then contraction in the granulation tissue will make that gap close. So repair response take place by, sorry, I can't see because of this pictures are coming in my way. So repair response participates in mesenchymal tissue, fibrocytes, stem cells, histiocytes, endothelial cells, macrophages, all these things are there in the granulation tissue, and they repair that surrounding area. And after the laying of fibroblasts and fibrin and collagen, then what happens is the collagen will contract, and wound gap will get reduced and wound will get closed. Right. So, three phases we can observe in granulation tissue: phase of inflammation, phase of clearance, and phase of ingrowth of granulation tissue. First phase, immediate following trauma, blood will get clotted, but the blood clot will fill that gap. And there's acute inflammatory process is going on, exudation of plasma, as you call plasma exudation, and a cellular exudation. Both will come out, and cellular exudation will have neutrophils, eosinophils, basophils, mast cells, and macrophages. Those are the most important cells in the first 24 hours. And then these things will secrete out mostly the tissue factors that we have listed on the regeneration path. This fibroblast derived growth factor, platelet derived growth factor, epithelial growth factor, all these things, cytokines will release from these cells, including the complement cascade, interleukin 1, interleukin 2, interleukin 3, interleukin 6, and all these factors will go out into the tissue, and they will attract more and more fibroblasts and neutrophils to come to that area. And that will try to encounter whatever the infected material, the bacteria, the viruses, whatever the pathogens which will try to get into the tissue, they will counteract by this cellular exudate. And the plasma exudate will also have antibodies, fibrin, and clotting factors, and those things also will get attached to these microbes that are coming in and try to destroy them and try to protect our body. Then what happens is the next few days, the combination of proteolytic enzymes liberated from neutrophils and enzymes and those phagocytic activity of macrophages clear the blood clot, debris, whatever came out from the red cells, and then those things will get resolved. Then what happens is, in the same time, on the two edges, the granulation tissues will start processing from two phases, and then there will be angiogenesis. That means new vessels on the cut edges of the capillaries will grow into the gap of the wound, and more fibrin, that means collagen, type 1 collagen will lay on this thing, and on the type 1 collagen, the new vessels will grow and grow and grow into the wound and clear the gap. Right? So angiogenesis is a very important part. Formation of new vessels at the site of injury make the place of proliferation of endothelial cells from margins to the severed blood vessels. So there are cut or damaged blood vessels in the margin of the tissue. From this margin, the endothelial cells will grow into the gap of the wound, right? That will be stimulated by the cytokines inside that gap. Now, the neutrophils and the exudate containing a lot of cytokines, and those will enhance the growth of these capillary cells. Most important, the vascular endothelial growth factor and the platelet derived growth factor, and the transforming growth factor beta. Those will increase the formation of angiogenesis. So wounds start to contract after 2-3 days, and then the process will complete after 14 days. That's why when we are, when we do a surgery, we tend to remove the sutures on the 14th day. That is the ideal day to remove. Now we remove the sutures a little early because we put some internal sutures. The external sutures we remove early because to reduce the scar of that tissue. But ideally, those days, they used to keep them to 14 days, especially the laparotomy wounds and the flaps. We took to 14 days still. So, myofibroblast appears to active granulation tissue and mechanism of wound contraction. Right? These cells have smooth muscle-like action, and then they bridge the gap between the two cell layers and try to contract and minimize the size of the wound. Now we use same things in pictures, so we'll understand it better. So initially, you will have the hemorrhage. Right? Initially, you will have the hemorrhage here. Now, if there's a cut injury like that, there will be hemorrhage here, and there is a blood clot. And the acute inflammatory process starts. The macrophages, the neutrophils, platelets, everything will get sucked there, and this thing, and those things will come out on that tissue edge, mostly on the tissue edge, and they will come into the gap also in the first 24 hours. The next after 72 hours, what will happen is there will be new vessels will form, and this gap will be reduced, and whatever the debris are being engulfed by the macrophages and the neutrophils which have come here, and they have all completely destroyed the pathogens they have come here, and then the new granulation tissue will form into these areas, and what happens is next the granulation tissue will contract and close the gap, and here the epithelium has completely healed, and you may there is a scar tissue underneath the dermis, but epithelium is completely healed out. That is regenerated, if you can say, it's completely regenerated, and dermis tissue you can't regenerate, so that will be kept by scarring. And the blood vessel also completely regenerated. Again, this is what we see in the incise wound. When you are put there and when the wound is sutured, there will be gap like that. This is the thread, or whatever the suture material that we have over right. So there is a gap like this. That gap will also have with a bit of granulation tissue, and there is scar there, and you can see in every suture that you have put as interrupted suture, there is a small tip of a scar is there in the corner. Whatever you do, you can see that. And collagen is the one that is filling these gaps. So, organization is the last phase. By third day, fibroblasts will make the wound area. By the fifth day, the collagen fibrils will forming and dominate the healing part. In fourth week, scar tissue will scatter everywhere. There is no macrophages or neutrophils by 4 weeks' time, and completely healed, and epithelium is formed. And to complete the scar contraction, that will take about 3 months. Then only we can say the scar contraction is also finished and wound is completely healed. That's why when you are putting your patient with hernias and things like that, we ask them not to wait there for at least for 3 months, because by only 3 months, the wound has completed the fibrotic part, and the fibrosis has completely healed, and fibrosis have contraction part also finished. Now again, this is in what we call healing by primary intention and healing by secondary intention. In healing by primary intention, the epithelial layer is sutured and it is approximated mechanically by us. So healing is much faster and healing is much complete. But healing on secondary intention, there's too much gap caused by the wound. So it has to take longer time. So we can't fill this gap. We can't approximate this gap. So what will happen is the gap will be filled by granulation tissue, and there's more granulation tissue, and there's more scarring on healing on secondary intention. Healing on primary intention, there is a scar but very small. Secondary intention, there is big scar, and you can see the scar outside. Right. So, what are the problems of wound healing? So they can get infected. Like even how much the body try to eliminate the infection, if there is a foreign body, or if there's a virulent pathogen that's got it, like Clostridia, Clostridia has various two types. Basically, Clostridia preferens is what I'm worried about. That causes gas gangrene. And some types of streptococci, those things also can get in and then they can cause severe infection. So our body pathological, the body mechanisms of counteracting the immune system that counteracting the infection may not be able to heal them immediately. So they can get infected, right? So implantation, a foreign body might get into it and we cannot remove it like, mostly military people who have been during the wartime, there are tiny bomb shell particles inside their body. Those are implantations. So they can cause various problems time to time. They can cause infections, they can have discharges, so they can cause sinuses, so they can have problems. Pigmentation. So wound can get, the wound scar can get darker than the normal skin area or lighter than the normal skin. Sometimes they get depigmented, right? So those both things can happen, right? So pigmentation can happen even if you are using a suture material with pigmentation. If you use pigmented suture material, the wound can get pigmented. The most common thing is when you are using violet colored suture material to skin, the skin can have a tattooing pigmentation. Right? So deficient scar formation. The scar is not enough. So wound is not getting healed. Right? There's a problem. So that may be a nutrition problem. That may be a infection problem. That may be some other problem because of the site of the tissue or the wound. Say, for example, if it happened there in a site of a joint where there's always movement, mechanical movement, the scar tissue is not going to be put layer there and it's going to be a problem, right? Hypertrophied scar. So there's too much scar tissue formation, and that is hypertrophied scar. Much too much scar formation causes keloid. That means the scar tissue is bigger than the wound itself. Right? So lastly, any wound can undergo malignant transformation. There's a risk of malignant transformation of any wound because this epithelium proliferation can undergo any type of mutation and then can have a malignancy, especially the burn scars, large scars, which can get re-ulcerated due to ischemia, and those can cause something called squamous cell carcinoma can arise from these areas, which are called marginal release ulcers. So factors affecting wound healing. There are local factors and systemic factors. So if you take the systemic factors, age. The neonates, children will have very good wound healing. And now there's an entity called fetal surgery. So the surgeons are operating on the fetus itself. They say if you do fetal surgery, there is no scarring. The skin itself will regenerate and the damage will completely regenerate and there is no scarring. So age, younger the patient, better the healing. Older the patient, so the same way, older the patient, there's little more delay in healing. So all the factors are there. Age itself is a factor that everything is slow, and older the patient, wound healing is delayed. Nutrition, very important factor. So you need protein for your wound healing, especially proteins containing collagen making proteins, proline and hydroxyproline, and vitamin C and zinc. If you can remember your biochemistry, proline and hydroxyproline, you need to hydroxylate the proline, you need vitamin C. So the process is stimulated by zinc. So you need all these things for formation of granulation tissue. So you need a lot of protein and a lot of energy also if the wound is large, and you need zinc, selenium, and vitamin C are the most important factors. And other vitamins are also much more important. But ultimately, what I'm trying to tell you is you need high protein a little high protein, balanced diet for the wound healing. Systemic infection. If the patient is having a systemic infection like a pneumonia or sepsis due to a renal urinary tract infection, that itself will delay the wound healing. Uncontrolled diabetic, everyone knows about the uncontrolled diabetic will have a lot of problems. There are diabetic macrovascular disease and microvascular disease directly affecting the part of local wound healing. At the same time, when there's high sugar levels and ketosis, both will cause inactivity of neutrophils. So there you can't, the neutrophils won't be acting on the normal way of pathogen killing, so they can have infections. Hematologic abnormalities like sickle cell anemia, those things can cause it. Chronic organ disease, chronic liver cell disease, chronic renal failure, COPD, heart failure. If they're having any kind of a chronic major organ failures, they are having delay in wound healing. So other than that, local factors, infection. Local infection is the main problem. Poor blood supply, right? So venous obstruction also comes as blood supply. When there's delay in wound healing, that means the delay in abnormality in venous taking out the venous blood from the tissue area, that will accumulate and that will cause problems of arterial supply, cause venous ischemia. Right? So that's it also comes to blood supply. Movement, like I said, if the wound is there in joint where there's constant moving, so there is the tissue can't catch each other. The two ends will not be approximate each other because of constant moving. Exposure to ionizing radiation. If the patient had any irradiated tissue, there's poor wound healing because of poor blood supply on that tissue. They get endarteritis. Foreign body. If there's foreign body inside the wound, there's difficulty in wound healing. Bone involvement, right? Chronic osteomyelitis. With malignant transformation of the epithelium, that's delaying wound. So we need to find out what makes the wound healing delay. So when you're assessing now, like in the earlier lecture, was describing how to describe the wound. Now, when you are describing the wound, you know whether the wound is healing or not healing. If you are thinking the wound is not healing, then you should think finding out why the wound is not healing. Then you have to go back to the history of the patient, find about their nutrition, find about the systemic inquiries, find about their chronic illnesses, any hematological abnormalities in the family history, then see the wound for any infection, blood supply, venous return, and pulse movement, at the site of the thing for the movement abnormality, asking the history for previous irradiation, and examine for a foreign body there can be, and take X-ray and see if there is any osteomyelitis. And if the wound looks like a malignant tissue, or your assessment shows overgrowth of the thing, the epithelium, what you call everted edges of the epithelium or rolled up edges of the epithelium, that means it's highly likely to be malignant. So you take a biopsy and make sure it is not malignant. So management is completely different if it is malignant wound, right? Now, this is the barriers for wound healing. Now, this is very, very important thing on the assessment of your patient, right? Now, there are various factors as barriers. One is the client, the patient. Patient is the barrier. Okay? So, receptive patients are good. Patient is very receptive. Whatever you ask the patient will do that for you. You ask the patient to eat well, 3x, patient will eat 3x or problem 4x, right? So, at berry, sometimes they are very difficult to manage. They will not do whatever the things that you ask to do, right? So, he doesn't want to reveal the finances, unwilling to discuss the expected plan, and he is not helping you to heal the wound. the family. There should be a good caregiver, and the family also should be there. And when you ask the patient come in 3 days time, the family should be able to bring the patient in 3 days time. Otherwise, there are difficulty in managing this kind of patient, those who are not compliant with the plan. Case manager, the main wound caring expert. So his knowledge, previous experience, planning, and all these things are important in wound management. The program. So you need to have program. What are we going to do? Are we going to stop this case? Are we going to give any nutritional support? Are we going to, revascularize this patient? Are we going to do a bone graft or remove the bone? You don't have a plan, right? And that's also very important for a wound healing. The system, that is the government of healthcare system, our Department of Health. Right? So system also should be helpful. There should be adequate amount of drugs, dressings, and other needs that we need for the wound healing. If these things are not there, we have a problem. Microbiology, that's a very important part in microbiology because there are good microorganisms and not so good microorganisms, right? The common cells, those are the good ones, and the pathogenic. So the good ones maintain the skin barrier. They don't do anything to the skin barrier, and they increase the interleukins and the other cytokine factors and keep the wound environment good for healing. And the pathogenic ones, they are the difficult ones. They make biofilms, they get pathogenic, they produce inflammatory cytokines, and there is more and more attraction of the pathogen, the neutrophils. So neutrophils are good in the early phases to remove the debris, but they are not good at the healing phase. If they come on the healing phase, they will destroy the cytokines and the cytotoxic activities of neutrophils and macrophages will destroy the healing wound, the new epithelium and the new angiogenesis. They might destroy, right? So those things are very important factors of wound healing, the wound microbiology. Right? So common microorganisms which are causing problems are Pseudomonas, E. coli, and Streptococcus and Streptococcus, right? They are the ones who are making trouble to us most of the time. So we need to do a wound culture and see whether these things are there or not. Okay. So that is come the end of my lecture. So any questions, I'm happy to answer.
Sir, what is the difference of incised wound and laceration?
Incised wound are controlled cut wounds, like you cut a tissue with a scalpel, that's an incised wound. Laceration is actually laceration has more tissue damage than incised wound. Incised wound, only the cut a part is damaged. Laceration is like, when there is head collided on the wall, there is a crack on the tissue. Right? Tissue cracking is what you call laceration.
Thank you, sir.
Tissue control cutting is called incision. Right? Although again, tissue peleno, that's a laceration.
Hello, sir.
Yeah.
in your lecture, you have said we are do the suture removal after 14 days. It means after contraction of the wound. But I have noticed in some incidents we are removing sutures around 7 days.
Yeah.
So it means are we removing that sutures before wound contraction
No,
occurs?
not really.
It depend on
Now
other factors.
the conventional way of wound removal is 14 days. Now we have come down and we can remove it early. Now, for example, face and the neck areas, we try to remove the wound sutures within 72 hours. And other areas like in hernias and things like that, we remove around 7 days. And the laparotomy wounds and mastectomy flaps, and when you are doing a flap to cover that area, like amputation, stump like thing, that kind of thing. At that point, we might remove it in 14 days time, right? So the reason for that is we put a subcutaneous sutures most of the time. So subcutaneous would the suture will hold it up. It is not coming out. And sometimes face from 3 days time, when you're doing face and neck, it is 3 days time. If you are putting interrupted sutures in 3 days time, removing, we put something called steps. Have you seen steps? The plasters which can be put in in a wound. So
Yes,
what
sir.
we do is we put steps in between these interrupted sutures and remove the interrupted sutures. So steps will hold it up.
Okay, sir. Thank you very much.
Right? And ideal, if we have only put skin sutures without any subcutaneous or deep dermal sutures, they should be kept for 14 days. If you have put subcutaneous sutures and subdermal sutures, then you can keep your skin, you can remove your skin sutures early.
Thank
Clear?
you very much.
Yes, anything else?
I think there are some questions in the chat box, Rangan.
Okay, so sorry, we'll see.
Look at it. Yeah.
Date of suture removal depends on site also. Yeah, yes, I told you why it is there, right? Right.
Basically, that's all. So,
Yeah. Any recommended book or website read about wounds?
I shall put some
Yeah, then I think
articles.
they can put something there, because this to learn about the main biology of the wound, I think the usual standard pathology book will tell you about wound healing, and that amount of knowledge is more than enough for a person who is clear managing the wound. Knowledge is more than enough for a person who is managing a wound, right? So yeah, okay. Anything else?
Anybody? I mean, we are at the end of the time slot also. But yeah, other thing is now this lecture you have to you have to apply that into your patient and write a part of your assessment assignment. Uh, this is one of the topics, the wound
Basic.
biology.
No, there's a question is the basic question. Difference between ulcer and a wound can be divided by external or internal factors caused. No, not really. The wound is anything which damages the tissue. Ulcer is a discontinuation of the epithelium. There can be a wound without discontinuation of the epithelium. That's the conclusion. But ulcer is always a wound because there's damage to the epithelium.
I think now we can finish the session. No, now it's almost 11 o'clock.
Yeah.
If they don't have any questions. And
Yeah,
but any
the recording
questions
will be
they can post.
available. Yeah, well, the recording will be available probably tomorrow, maybe. Our IT doctor can tell us when it's available. She will, I think, post it in the YouTube as well as the link in the WhatsApp. So you can refer to that. Next week we'll discuss about the assignment and then you can start. So, but this will definitely be a topic. In that you have to now you have to think how to apply this knowledge into one of the wounds that you might select to do your assignment. So it's you have to practically apply all this knowledge into that particular wound. So if there are no questions, I think, madam, shall we wind it up?
Yeah, we'll wind it up. And good night to everybody. Thank you for joining, and please join at least 15 minutes before next Tuesday. Yes, we always keep your numbers and join. Otherwise, today also there were a bit of the mishaps happen. So please put your numbers rather than your names, and try to join a little bit early.
Okay. Thank you and good
Thank
night.
you very
all.
much and good night.
Good night.
Thank you.
Thank you, sir. Good night.
Thank
Good
you.
night.
Good night.